sir. Good morning, everyone. I am Dr. Badika. I am first year FNB trainee in Apollo Hospitals, Greens Road, Chennai. I am here to present a seminar on the ICG in minimal access surgery. I will give a brief introduction and the history. Kodak Laboratory made the initial discovery of the ICG in 1955 for use in near infrared photography. So it's basically non-toxic fluorescent iodide dye with a rapid clearance from the liver. So it was approved by US FDA for clinical and research use in humans since 1956. It was originally used for quantitative measurement of hepatic and cardiac function. The fluorescent properties in the 1970s expanded its use to ophthalmology and to other specialties over the last 50 years. So this slide shows a brief about the ICG metabolism. First, the ICG is injected into the body, and in the blood it binds to the plasma proteins and quickly circulates. After that, the fluorescence can be imaged within minutes. And then after that, it is removed by the liver and eliminated in the bile. ICG is exclusively metabolized by the liver. The dye it is cleared in the first 10 to 20 minutes after application, with a half-life of generally 3 to 4 minutes. Its elimination depends on three things. The first one, hepatocyte function. Second one, the liver blood flow. Third one, the bile secretion. So, the rate-limiting step in the clearance of ICG from the body is the hepatocyte uptake of the dye via carriers. So, as a bit of physics, the clearance it follows the first order kinetics with the rate of clearance matching the rate of uptake. So, this is the showing the first order kinetics. As the concentration of the drug is more, the rate of clearance is also more. So, that is the first order kinetics. So, this is the showing ICG fluorescence principle. ICG is injected into the circulating blood volume and the fluorescence is seen by the camera. Fluorescent property, the ICG molecule is excited between 750 and 800 nanometers, and the maximum peak, that is at the wavelength of 832 nanometers, the fluorescence can be seen. The Indocyanine green uses water as the solvent, and the concentration should be kept below 15 mg per liter, because in higher concentration, ICG molecules have the tendency for aggregation. Uses of fluorescence imaging, basically it is used for locating anatomical structures and for delineation of diseased and normal tissue. When we just see with the laparoscope, we might not be able to make out. So it helps in enhanced localization of the tumors and the lymph nodes. And intraoperative assessment of margin status. And then real-time visualization of organ perfusion. Perfusion, when we just look, we may not be able to see which is the perfused organ, which part is perfused, which is not perfused. But the ICG, it helps to delineate very clearly. And coming to the safety of the ICG, of the injected ICG, 98% is bound to plasma proteins, while the remaining 2% is free in the serum. The decomposition reaction of ICG releases singlet oxygen molecules that bind to the breakdown products and thermally decompose into carbonyl compounds of low toxicity. Because the singlet oxygen remains within the ICG system, the dye has a lethal dose of 50 to 80 mg per kg. The standard dose of less than 2 mg per kg, ICG is virtually non-toxic, provided the patient does not have an iodide allergy. So this one is taken from this paper, that is fluorescence properties and metabolic features of Indocyanine green as related to angiography, that was published in 2000. Clinical applications of ICG. ICG is useful in the colorectal surgery, HPB surgery, upper GI surgery, surgical oncology, and ophthalmic and neurosurgery. ICG in colorectal surgery. ICG helps to identify bowel perfusion and lateral lymph node dissection and localization of tumor. Bowel perfusion, evaluation of perfusion of the supposed proximal colon transection. So this photo, it shows bowel is looking normal only. But in the second one, after injecting ICG, you can see the perfusion is only till up to this part is only perfused. This part is not perfused. So we are transecting at this point, and then this photo is showing colonoscopy. Under colonoscopy, we are seeing the for ICG fluorescence angiography versus visual clinical assessment of blood perfusion of the anastomosed colon and rectal stump, that is non-ICG. The endpoint was to assess whether ICG was associated with a reduction in the incidence of anastomotic leakage. Secondary outcomes were the rate of post-op complications and change in the level of bowel resection. So a total of 380 patients underwent sigmoid and rectal resection. They were enrolled. After randomization, 3 patients were excluded. The result of 377 cases were available for analysis. 187 had ICG fluorescence angiography and 190 had non-ICG. The ICG group identified impaired blood perfusion of the colon, that is in 36 cases, 19%. Anastomotic leakage developed in 48 patients, that is 9.1%. 48 patients totally, 17 in the ICG group and 31 in the non-ICG group. So only 9% of the ICG group, but 16% in the non-ICG group. So ICG fluorescence angiography did not decrease the rate of anastomotic leakage of high anastomosis. In contrast, a decrease in the anastomotic leakage was found for low colorectal anastomosis in the non-ICG fluorescence angiography group. So, to conclude, ICG fluorescence angiography is associated with reduction in the anastomotic leakage following no anterior section. So, this is a paper that was a study investigating perfusion of colorectal anastomosis using fluorescence angiography. So, ICG in colorectal anastomosis, this is a phase 2 trial. Confirm the feasibility, low cost and high success rate of this procedure, reporting a leak rate lower than expected based on a historical series with particular reference to rectal anastomosis. Usage of ICG by surgeons. 72% of surgeons use the fluorescence by default in all lab interventions. 27% consider fluorescence only in selected cases, but there is no agreement on which these are. That is high-risk patients, high-risk interventions and intraop uncertainty. ICG fluorescence imaging in colorectal surgery is a paper that's a snapshot from ICRAL study group, published in 2021. So this shows the lateral pelvic lymph node dissection. ICG dye is injected into the submucosal layer on the distal side of the tumor through the anus immediately before surgery. So this picture we cannot make out where is the fat, where is the lymph node. It's very difficult to make out. But in this picture, these are all the uptake by the lymphatic tissue. So they are all draining the tumor. So all these lymph nodes, all this we should clear. So even after clearing, if we see any more residual somewhere green light is coming, that fluorescence we can see, that also we should remove it. And then ICG group experienced a significantly lower intraoperative blood loss and a larger number of harvested lateral pelvic lymph nodes. It helps to distinguish lymphatic tissue from vascular and nerve structures. That is what I was explaining. It is given in the ICG guided laparoscopic lateral lymph node dissection, that paper for rectal cancer, published in November 2019. Tumor localization. Accurate identification of the location of the colorectal tumor is crucial in minimal access surgery, because here we don't have the tactile perception. So here we can very well see this is the location of the small tumor that is picked up by the ICG. So it is important for cancer at an early stage because of small size or location on a mobile part of the colon. Preoperative colonoscopic tattooing with ICG. The tattoo group had a significantly shorter operative time, less blood loss and a shorter hospital stay than the non-tattooed group. It's given in the paper that is published in 2018. Urethral visualization during transanal time. Transanal total mesorectal excision. In the transanal total mesorectal excision, there is a risk of damage to the urethra. So, to prevent that, we are instilling directly the ICG into the urethra through the catheter for NIR fluorescence. But however, there is no final specific recommendations from the clinical use of ICG fluorescence imaging to identify and prevent urethral injuries. But this injecting the ICG directly into the urethra is very helpful for visualizing during the transanal total mesorectal excision. So now we are coming to the role of ICG in upper GI surgery. This is a paper that is showing clinical applications in lap radical gastrectomy, class 1 trial. It's a retrospective study. ICG group 109 patients and control group 88 patients. The ICG group had a significantly larger nodes retrieved, shorter total operative time and shorter dissection time, and blood loss was also significantly less. So as we can see, p-value is less than 0.05, less than 0.05, so it is very much significant. So this picture is showing ICG in lap radical gastrectomy, that is a class 1 trial. First photo we are seeing the stomach, then second one is showing the number 6 lymph nodes that is picked up by the ICG, and this is the splenic artery and the splenic vein. So these are the lymph nodes that are picked up, that is showing the green light, and then all this we can see the fluorescence is very well shown. Left gastric artery, common hepatic, and these nodes also we can identify with the help of the ICG. So finally all the nodes have been dissected. ICG in HPB surgery. Surgeons performing hepatobiliary surgery often faced with the difficult and aberrant anatomy. As we know, there are so many variations in the anatomy. So one limitation to ICG is the background fluorescence from the liver. However, it can be improved by precise timing of ICG injection preoperatively. ICG in HPB surgery. The exclusively hepatic metabolism of ICG results in biliary excretion from 30 minutes after injection, enables visualization of the biliary anatomy, which is useful during difficult cholecystectomies. Right. The majority of the studies, including the review, use 2.5 mg administered within 1 hour before imaging for lap cholecystectomy. It's a randomized control study that is published in 2021. So this is showing lap chole with apparent bile duct detected by intrafluorescent angiography. It's a case report. So first photo we are seeing the cystic duct CBD, and this is some aberrant duct that is going, and it is very well picked up in the ICG. So now we have avoided damaging this duct, and then it has been preserved. Only the cystic duct has been clipped and divided. Role of ICG in minimally invasive HPD surgery. ICG gains more and more recognition in minimally invasive liver surgery in Western countries. Recent haptic feedback for tumor identification is missing. Needs other tools to reach sufficient oncologic results. The intraoperative ultrasound and even contrast enhanced technique can facilitate, but ICG adds more precision. ICG also helps in anatomical liver resection by identifying individual liver segmental anatomy of the liver. So role of ICG in minimally invasive HPB surgery. So this photo is showing the fluorescence that is the liver mets that has been picked up by the ICG. For identifying segmental anatomy in liver resection, Ishizawa et al. Has demonstrated positive or negative staging techniques for liver segment delineation in lab hepatic dissections. During positive segmental staining, the portal vein is punctured under sonographic guidance to the liver surface with slow injection of ICG. So this is the positive staining. Intraoperatively, direct ICG. Intraoperatively, direct ICG is injected under ultrasound guidance, and that one is showing the segment of the liver that needs to be resected. In the negative staining technique, the Glisonian pedicle that corresponds to the segment to be resected is dissected and clamped, followed by the use of intravenous ICG, which stains the remaining liver. So in positive staining, we are directly injecting into the portal vein, and that segment which has to be resected lights up. But in negative staining, during dissection, the perfused remnant liver is green on the surface as far as intraparenchymal. So remaining one we are removing. So this is the positive staining showing a lab direct intraoperative ICG injection under ultrasound guidance. The stained segment becomes green with fusion image camera. So robotic ICG guided anatomical liver resection in a multi-center cohort, an evolution from positive staining into negative staining. This is the part of the liver that has been perfused, so it is picked up by the ICG. Uses of ICG in trauma surgery, fluorescence guided surgery. So this is a paper that was published in the World Journal of GI Surgery, a review of current evidence and implementation in trauma patients. ICG is used in biliary mapping and leak detection. It's used in ureteric mapping, thoracic duct mapping, and also for vascularity. Identifies vascular injury, bowel injury, bone depth assessment, tracheal injury, soft tissue injury, abdominal reconstruction surgery, and other flap reconstruction surgery. ICG in colorectal liver metastasis. Colorectal liver metastasis is accessible for ICG visualization as well. The surrounding fringe of immature hepatocytes with reduced bile excretion capacity shows a rim-type fluorescence pattern. but it's only useful for subcapsular lesions. That is, only the 1 centimeter deep lesions that we can pick up with the ICG. That is, if it is too deep, it's difficult. And the use of ICG has the potential to improve lesion detection rates, increase the likelihood of achieving R0 resection, enable anatomically guided resections. Limitations of ICG is low specificity. Use of near-infrared fluorescence techniques in minimally invasive surgery for colorectal liver metastasis. That is the paper. And identifying chyle leak. Indocyanine green lymphography, subcutaneous injection of ICG into nearby lymph node regions. Chyle leak can be imaged intraoperatively with near-infrared camera system. It is used successfully to detect suture leakage and repair chyle fistulas in the chest and abdomen. So this is the photo that's showing video-assisted thoracoscopic duct ligation following chyle leak after radical neck dissection. So this photo shows the thoracic duct, and there is a leak of the fluorescence dye, and here it shows the thoracic duct that has been clipped. So this one is a forest plot of the ICG fluorescence guided surgery versus ICG on anastomotic leakage in colorectal surgery. European Association for Endoscopic Surgery consensus on indocyanine green fluorescence guided surgery is the first consensus on ICG fluorescence guided surgery. Fluorescence cholangiography during lap cholecystectomy to improve the visualization of the biliary structures. So these are all the results that they found out after that study. ICG fluorescence in colorectal surgery to assess tissue perfusion to reduce the risk of anastomotic leak. ICG fluorescent lymphatic mapping is safe and feasible to allow identification of lymphatic anatomy during colectomy for cancer. Although the clinical value is yet to be defined. The use of ICG use of ICG fluorescence in liver surgery to aid identification of bile leaks after liver resection. Use of ICG fluorescent lymphatic mapping during gastric cancer surgery to improve lymphadenectomy. Laparoscopic sentinel lymph node mapping using NIR fluorescence with ICG in early endometrial cancer. Laparoscopic staging with sentinel lymph node biopsy using ICG is a practicable approach for nutrient-limited disease on preoperative evaluation. It extends the benefits of minimally invasive surgery to these patients while overcoming the limitations of excess cost or availability of expensive robotic equipment. So here it's showing that fluorescence, the lymph nodes have been picked up. In oncosurgery for sentinel node and lymphatic mapping. It requires only 1 to 2 minutes for ICG to follow lymphatic vessels after injection. High area fluorescence will indicate the lymph node of interest. The simplicity and sensitivity of ICGA makes it attractive alternative to a radioisotope. Main limitation is it detects superficial lymph nodes only because of low light penetration. The dissection must be completed half an hour before rapid hepatic clearance of the ICG. So, coming to the summary, in a fluorescence guided surgery, has assisted surgeons in enhancing visualization and minimizing complications. ICG is easily available, non-invasive, and with wide margin of safety. Fluorescence imaging using ICG is useful to both open and lap surgery, and routine use of ICG provides more objective assessment of different surgical circumstances. So these are the references. Thank you.
Thank you. Dr. Krishna?
Yeah, thank you, Dr. Balika. So, trainees, you may type your questions, comments in the chat box if you have any. Dr. Piyush, you may continue, sir.
Yes. So, very nicely presented. The indications are ever growing, but primarily, if we divide the indications, one is to delineate the anatomy, second is to see the perfusion, right? Whenever we are contemplating any anastomosis. But only problem with that is you have injected ICG and you can see a tissue which is less perfused, say colon is less perfused, right? You have shown that in the flag trial that low colorectal anastomosis are very well picked up, anastomotic lean is very well picked up, right? But the problem is you have less perfusion on say ICG, right? ICG imaging. So what you will do? Based on that, are you going to dissect that area or you will just wait? So that
We wait.
yes, you wait. So ultimately, we rely on our clinical judgment. More
Yes, sir.
yes. ICG gives you an idea that this is less perfused and this is more likely going to give well later on, right? So this is important. And in laparoscopic surgery, in anatomical deletion, we can very well delineate the bile duct and the ureters. These are the two common areas wherein ICG plays a very, very important role nowadays. Then picking up tumors. We call it FI, fluorescence imaging. So it acts as a diagnostic modality also, right? Now, can you tell me how does it work? How does this ICG work? What is the principle behind it?
That is, a tumor will have more blood supply, sir. Tumor will be very hyperperfused, and so it picks up the ICG.
So there is a phenomenon called enhanced permeability and retention. So there is new vascularization.
New vascularization, yes, sir.
The vessels are quite dicky to start with. So once we give ICG or any other fluorophore, it gets accumulates there preferentially as compared to the other tissues, and it remains there for a longer period of time. So permeability is more, but enhancement is also there. So this phenomenon is the basic principle behind diagnosis of these tumors, right? And whenever you inject a fluorophore, you give it intravenously, right? It goes to the organ, it takes up these fluorophores. Okay. Now, if you give some light, okay, and after taking the fluorophores and with the light, they get excited. The electron goes to a higher orbit. If you go back to your chemistry classes, so these electrons are excited and they go back to a higher orbit and they emit light, fluorescent light. You cannot see light. You can see light only in the visible spectrum. You cannot see infrared light. So you need a camera for that, right?
Yes, sir.
Those camera has now been incorporated with the traditional cameras that we use during laparoscopy, right?
Yes, sir.
So those cameras will pick up that fluorescent light. So ICG, the exciting wavelength is around 802, 820 like that.
Yes, sir.
If you put a near infrared and look with the camera, you can see the fluorescent part. Right. So this is the principle. Now can I ask you what are the disadvantage or problems associated with ICG use?
That is a very deep location. It's very difficult to see.
Beyond 1 centimeter, it is difficult. It cannot be seen. Okay. What else?
And that's what, sir. Dissection should be completed in half an hour because the rapid clearance of the ICG by the
half-life is within 4-5 minutes, right? So if and initially it goes to the vessels. So if you are planning to look at the vessel or perfusion, you need to see within few minutes. And after that, what it does, it goes to the it is taken up by the liver. It gets metabolized and excreted in bile. So if you want to see the biliary tree, you will have to wait for 30 to 40 minutes, even more. And very rarely one can have anaphylactic reactions. 1 in 10,000 person can have anaphylactic reaction because of the presence of sodium iodide in this. So these are the few disadvantages. And most importantly is the availability. Very few centers have this machine now, but of course we'll have more machines. So I'll now take the questions. Yeah, ideal time to give ICG before lap cholecystectomy. So as I've discussed, you give intravenously. The half-life is around 4 minutes, and you all know that within five half-life the drug gets excreted. But with ICG, what happens? What happens is it is taken up by the liver. That's why it was used for knowing the function of liver,
Yes, sir.
right? Because of this property. Now, after going through the liver, it comes to the or excreted in the biliary tree. So we are interested in lap chole. We are interested in the biliary tree, biliary anatomy, particularly in the CVD or any presence of any apparent duct, as shown by the presenter today. So we should ideally be injecting this at least 30 to 45 minutes before you start the procedure, so that once you are in the callots, you have an idea of the biliary tree. So this is the timeline. Yes, if the of course liver will take up ICG and you can see that, but you wait for a while, it will get excreted in the biliary tree. So the background liver will have less fluorescent as compared to the biliary tree. This is how we avoid the background liver light up. Any other question?
Dr.